And I'm going to welcome everyone to this month's Open Medicaid Adult Dental Benefit Learning Collaborative Call. This is Stacy Chazen with Open, and we're happy to have you all here. So today's call is being recorded. We have about 17 people on right now. The number's ticking up a little bit, so we'll ask you to keep yourself on mute until you're ready to ask a question or share something, and also encourage you to use the chat. So I'm going to turn it over to Colin.
Great, thanks, Stacy. Hi, everyone. Welcome back. So we have a few things on our agenda today. I believe, as Stacy noted in the announcement, we're going to try to spend a good bit of time today talking about consumer engagement strategies, especially as we've got a number of states who have either passed expansion of Medicaid adult dental benefits or are inching ever closer to doing so. And now the question becomes implementation. And I know that previously we talked a little bit about the ways in which we should be considering engaging current and potential beneficiaries in conversations around things like benefit design and the other ways in which the program affects their access to and quality of oral health care. But before we do that, I think we're going to have a couple of state level updates. One of which is Parisa Charmsky-Goodwin from the Connecticut Oral Health Initiative, who will be telling us a little bit about what I think is a pretty innovative approach to closing coverage gaps. It's sort of Medicaid adjacent, but does utilize the Medicaid 1115 waiver mechanism. And then we'll also hear from Kathy Kilrain Del Rio, Maine Equal Justice, on update on where things stand in Maine with their Medicaid adult dental benefit efforts. So with that, I'm gonna and sorry, I'll pause here to see if Stacy, am I missing anything on the agenda?
And Chloe Van Zandt is going to talk about consumer engagement strategies in Virginia.
Yes, from Virginia.
You knew there was something. You knew there was something you forgot.
Yes, I knew there was something.
Sorry, Chloe.
All right, so I'm going to start us off with an update from Kathy on how things are going in Maine.
Thank you. Hello, everyone. I'm Kathy Kilrain Del Rio. I'm the Advocacy and Programs Director with Maine Equal Justice. I use she, her pronouns. So we've been very busy with our implementation for the adult dental benefit here in Maine. And just a little context for folks, I know I've shared this before, but we had specifically included in our original bill, all the various versions of our bill, language that would require the department to work with stakeholders, including either impacted people or at least representatives of impacted people in their process. And through the work session at the legislature with the Medicaid director here, had decided like the best venue for that is this subcommittee on dental that we have at our Maine Care Advisory Committee, which I chair. And when they moved the language from the bill into the budget last year, they kept that language, and we would have pushed to keep that language anyway. So the department was required to work within the structure of having stakeholders present to be able to think about the implementation process and what the benefit would look like. And also at the same time that we got the adult dental benefit, the state also put language into the budget to increase rates for dental benefits, and not just for adults. It also, the rates piece affects kids as well. And also, while they had the adult dental benefit being worked on, they also tried to improve the kids benefit. So since last August, that subcommittee, which was already in place before the budget passed, has had representatives from the policy team at Maine Care, our Medicaid program, who've been coming monthly to our meetings to get feedback. They shared with us like what states they were looking at for comparative benefits, what their process was in looking at like commercial plans, and how how they were getting information about best practices. And then, so also that gave us an opportunity to provide feedback. And that subcommittee, you don't have to be a member of the Main Care Advisory Committee in order to be a member of that subcommittee. So that subcommittee has lots of people who are oral health care experts, and also people like me who represent Main Care members. And then there are even some providers that have been pretty consistent in attending. And so that had been a really good process. I feel like they were really open to feedback. They were very responsive when people suggested like looking at like another state that they hadn't considered and things like that. The process, as always happens at the state level, has taken longer than anticipated. They had originally hoped to have like a draft of what the benefit would look like by the early in this year, but they had contracted with a dentist who we had worked with actually on our campaign, Dr. Wallawinder, to help review the codes and all that piece of work. And so by the time we actually saw like a draft of what the benefit would look like at like the code level, it was already going on the end of February, beginning of March. But we were able to provide feedback at that point in the process as well. And they were very responsive again to that feedback, including like written, even though this wasn't formal rulemaking, they did give us like written responses to people's comments. And then the rates, they finally got to the point where they were ready to propose the rate changes. And again, like really took a lot of feedback around the rates, had someone from the rates department come to a subcommittee meeting to like talk with folks and do a presentation, and then also took like ongoing feedback about that. Even as of today, they're still taking feedback. In the end, originally the plan was that they were going to do the rulemaking in April, so that it would be in place by July 1st. But often when they decide they're going to do emergency rulemaking instead of like the regular rulemaking process, we're nervous that they're going to do something that we don't like. But in this case, we were glad that they decided to do an emergency rule because it allowed them to have more interaction with the provider community, because once they did the proposed rule, it would really limit what they could talk about in terms of the benefit change, the policy changes, as well as the rates changes. So we were supportive of them deciding that instead of trying to push and get the proposed rule out in April, they're going to do an emergency rule sometime soonish, before July 1st, and then at the same time, they'll put forward like the proposed ongoing rule. And it will definitely still be in effect by July 1st. And there, as I think I've shared before, like throughout this whole process, I would say one of the biggest concerns has been around the provider network and the fact that there are so few providers who accept Main Care. And of course, that's been exacerbated by the pandemic because of other workforce challenges. So another piece I just wanted to share quickly was that the department has been open to that as well. I mean, I think my opinion is that they genuinely want people to be able to access this benefit. They recognize that not everyone's going to be able to access it right away, just given the provider network. And they wanted to try to figure out ways to do more outreach to that community. So they held a forum a couple weeks ago that was specifically focused on rates and was targeted at providers. And it had great participation, I think. And they are doing a forum actually tonight, again, with providers about the policy changes. And throughout this whole process, we've also been able to share like different aspects of the draft benefits and the draft rates with providers who had expertise in certain areas if they weren't already present at the subcommittee. And so I think after they get the feedback in this forum, they'll have gotten to the point where they've gotten most of the feedback they want to get, and they'll be ready to make the proposed rule, but we'll still have a chance at that point to do comments as well. But all of this will hopefully, it's still going to be in effect on July 1st. And then I think the big question for us that we're still working on is like, what's the message to people? Because we want them to know that that benefit is now in place when it goes into effect. And we want them to know it's important to access that benefit. And also we recognize that people are going to have a hard time finding someone to see right away, especially depending where they are in the state. And so trying to figure out like, what does that message look like so that people don't just give up or feel like it's not that we haven't made any progress, even though this is a big thing. And so we haven't figured that out yet. We're going to talk more about that at our next subcommittee meeting, which is next month. And I think it'll be it'll be a process. But one thing I will say about all of this, I think the fact that we had the language in the bill that forced them to work with stakeholders was really important, because it created a space for this work to happen. And I also think the fact that we had been able to get a lot of media attention about this, about our various bills over the last few years, and a lot of attention when the budget passed last year that it included this benefit, that put a lot of pressure on the department to feel like they need this to be a success, especially it's an election year and the governor's message is about healthcare access. And so like not wanting a July 1st implementation to feel like they didn't do the right thing. So they've been really, really good to work with in this process, which is not always the case with everything that we do. But anyway, so that's where we are now, and we're excited for the next step.
That's great, Kathy. Thank you. Anybody have questions for Kathy?
Kathy, I have a question. Hi, this is Nancy from Hawaii. You may have mentioned this, but did you have issues with the cap on benefits for each participant, and how did you guys process through that?
That's a great question. So our benefit passed as a comprehensive benefit with no language around capping benefits, though of course in the creation of the benefit, there are places where they've like set limits on what can be done in, either in a year or in a lifetime, depending on the procedure or tooth, or many of you probably know more about some of those aspects than I actually do. But I think they've been really open to feedback. Like there was, I'll say just today, last night it actually happened, there was like an issue around how they're doing there was an issue that the number of times that they could do oh my God, I'm blanking on the procedure, but when they do the thing for children, especially with children, where they can apply the sealant or whatever to stop the dental caries. I'm totally blanking on the word. And so
silver diamond fluoride.
Thank you. Yes, thank you. Yes. And so there was like an issue because the way they have it currently drafted, it would put a limit on it that doesn't seem to be aligned with best practices. So the feedback was sent to the department, and there was some back and forth with the department, and I think there'll be more feedback shared at tonight's forum. But I feel pretty confident that they'll be open to that feedback. And also they had heard at previous meetings how important that treatment can be, especially for some kids. And so like I think they had actually like made the rate for that higher than it would have been under their normal methodology, because they wanted to incentivize that. But then this issue with how many times you could do it became a problem. So like, I feel like they've been really open to that. I will not say they were always open to those kinds of things in every conversation around rates and limits and benefits. But in terms of this particular benefit, I think they felt like this is their opportunity to try to set it up to be the best it could be. And so trying to make that work as much as possible. And my understanding from people who are more closely connected to like what children already can access, the changes that they've made in terms of that policy have also been really positive.
Hi, when you looked at the benefit at the code level, did you also get an opportunity to give impact in terms of the frequency? So for example, if it was an exam, as an adult have an exam 2 times a year, or is it once a year, or that type of detail?
Yep. Yes, we were able to give feedback on that level of detail. And I am 99% sure that like with regard to that specific piece, it is twice a year. But there's also, I think they were trying to strike a balance too of like recognizing how much unmet need there is, because many adults have not had care since they become an adult, and many didn't have care as children either. And so like wanting to create space for people to have that unmet need taken care of, so that recognizing like at least in the first few years, there might be a need for some procedures to happen more frequently than they would do if people had had preventive care all along. And they also, in terms of the rates, tried to prioritize preventive care in the way they structured the rates, given like what their pool of money was. And I mean, there's not a cap on how much money they can spend, but like they're trying to be responsible with their spending. And then, but for example, like recognizing there's probably a lot of people who need extractions right now because they haven't had care, and knowing that it's really hard to get oral surgeons to take main care, they kept the rate for that higher than it would be under like their proposed methodology in order to like provide space for that, at least for the next couple of years. And then we actually just passed the department had put forward a bill that just passed this year that creates like a whole new methodology for rates in Maine to be reviewed on a regular basis. And so when they would do that review, they could decide at that time, like, is that still the right rate for that procedure, or should it be changed given the whole context?
All right, thank you.
Thanks, Kathy. All right, I'm, for flow of content, I'm realizing I probably should have had Parisa go first, but, we're just going to roll with things here in my very disorganized approach to our agenda. I think what I'm going to do is go to Chloe next, if that's okay, and then we'll circle back around to Parisa, and then we can, explore a little further, in round robin, any other thoughts on consumer and beneficiary engagement. And Parisa, feel free to, add your thoughts on that perspective as well when you come around. So Chloe, give us your perspective from a state that's just a little further along here, at least in benefit implementation, at least.
Right, happy to. Hi everyone, Chloe Van Zant at Virginia Health Catalyst. I'm our Senior Policy Manager, so happy to share a brief update on how things are going in Virginia. At the beginning of the public health emergency, we had roughly about 650,000 adults that would be eligible for the benefit. That's around 800 and obviously continues to rise. But when the benefit was passed, roughly 800,000 adults became eligible. Just got an update last week that since the benefit went into effect July 1 of last year, 141,000 adults have been seen. About half have had a comprehensive oral evaluation, half have had a cleaning, and then there's some numbers about how many restorations and extractions. I was interested in what the percentage of utilization that was, and in some like really bad math that I would not advertise. If we take that 141,000 divided by approximately 800,000, that's 17%, which I think for the first year is really great. Thanks to HPI's incredible data, we know the average, which I think the data is a couple years old, but average is around 25% utilization, with the highest state having 33%. And so the numbers are looking okay. I can talk a little bit about trying to spread the word of the benefit, but I think from our perspective, we have not been in that space as much. We were spending a lot of time there the first 6 months after implementation, doing a lot of webinars, really focusing on community organizations and people that are interacting with Medicaid members. And so working closely with DSS, with food banks, with people that are doing eligibility for SNAP and TANF, just ensuring that all of those people that are interfacing with Medicaid members on a daily basis are aware of the benefit and at least know who to send people to if they have questions. We were able to do some social media around the benefit, had the language translated into 10 different, the verbiage translated into 10 languages, and had all of those social media posts out of just some advertising. But I think mostly we know in Virginia, the majority of our Medicaid members seek care at safety net clinics. Again, thanks to HPI's data, we know that only 11% of Virginia dentists are seeing Medicaid members. A few more are credentialed and not seeing anyone, but a small number. And so we've been working really hard on a reimbursement rate increase, advocating for that. Our legislative session ended in March, and we were hopeful to have a budget by the end of it, but we don't have that budget yet. They have to finish it by the end of June. So hopefully any day now we'll know about that. Virginia's reimbursement rate was 60% of private. And so we were advocating for a 30% increase to bring that up to 90%, and are pretty hopeful. We know that safety net clinics are having to subsidize a lot of that difference. There's one woman that we've been working with closely who runs a healthcare foundation that subsidizes the difference in dental cost at a local dental clinic. It's the only dental clinic in like the Culpeper Orange County area of Virginia, fairly rural. And she ran the numbers and found out that that deficit, because the reimbursement rate is low, can be up to $10,000 a month, which is insane. And so we were able to get her in contact with our budget patron. And so just her extremely relevant story of how much this reimbursement rate increase would help shore up our safety net clinics and help them be able to provide the care that is so necessary and that where members are seeking it the most. And so he's been able to take that story to the budget conference. So we're hopeful, but of course anything can happen. And just from her story, also noting that she stated clearly that they can't continue funding that. It's just unsustainable. And so hopeful for this reimbursement rate increase and continuing to partner with our dental association and dental association foundation and benefit administrator on ensuring that everyone knows about the benefit. And then I think also just looking at really creative ways to support the workforce of just, if everyone is going to safety net clinics, like what can we do to ensure that they're as equipped as possible? And so looking at dental assistants and dental assistant twos and just making sure that, I don't know, we're maximizing that. I think those were roughly the notes I had. Happy to add anything else or answer any questions.
Thanks, Chloe. Any questions for Chloe?
Chloe, this is Tanya in Kansas. Can you tell me one more time, because I wasn't writing it down when you said you're not very good math, which I'm sure is plenty good. It's on par with mine. For what the percentage of utilization was in the first year?
17%.
That's what I thought. Okay, just want to make sure my memory was right. Thanks.
Yeah, no problem.
And the average was like 25, is that what you said?
Mm-hmm. And I think Gary wanted to chime something in.
Well, it's not about community engagement, but it is relevant. And we're not yelling about this too much because the governor hasn't signed the budget yet. But to my amazement, we have managed to get the rates increased across the board for Medicaid dental. So I still kind of feel like it's not real, you know, until the governor signs. I have a little trouble talking about it because of that, because I always just think, you know, something's not going to work, but I think it will. So we're currently at about 40% of UCR, and we're going to go all the way up to 80% UCR. And so, yeah, I see the wow, Tanya. That's what we're all saying. We're pretty happy about that. The advocacy process for that was really interesting. I won't go into that now. That's a little bit of a story, but I will also, while I have the floor and we're talking about Missouri things, I will also mention that the coalition is funded to do through the Developmental Disabilities Planning Council in the state to do 3 pilot projects, one each year for 3 years, to increase access to care through teledentistry for people with IDD. And we're also working on an add-on project so we can play with alternative funding mechanisms, even with that gigantic rate increase, it's still a level playing field. There's no rate differential for people with intellectual and developmental disabilities, and they generally take more time. And so even with the rate jump, we're not going to see a bunch of new dentists say, hey, I want to serve those people with disabilities. So we want to get at it some other way to get more money into that, to up access for that population. People with IDD, you know, really have remarkably low opportunity to get dental care. So we think we've got a good way to pressure on that. Do we have a cap on benefits? We don't. Adult dental for most of the population served, if they're not permanently and totally disabled, are pregnant women. Does not include crowns or dentures. So it's considered a somewhat limited benefit. We'd like to do a lot of other things. We would like to see those things added. We'd like to see some other specific teledentistry codes. Medicaid does cover teledentistry, but we'd like some other codes added to enhance that benefit. But that's the news from Missouri.
Excellent. Thanks, Gary. So now that Missouri is, I'm trying to make a show me state joke here about like showing me the money and then showing me the dental care, but I can't get there. So
good try though, Colin. It's one of the dumbest state mottos, and you know, I never use it for anything because it's too stupid. But that's us.
It's definitely, it can't be the worst one.
Oh yeah, I think we're trying.
I'm going to move us on to Parisa's presentation, and then we can circle back around to more state round robin stuff and perhaps some more conversation around consumer engagement strategies. So Parisa, why don't you tell us about what's happened in Connecticut with this waiver, and then also, you know, if you have any additional perspective on, you know, engaging with Medicaid beneficiaries around how the dental system works for them, feel free to add that on too. Although I didn't prep you for that.
No, that's cool though. I'll go for it. Thanks for having me. And I do want to say, I think Show Me State is a lot better than in Connecticut, the land of steady habits, because that is not a good slogan for advocating for change. But we get around it sometimes. So I'm going to tell you a little bit about the 1115 waiver and plan to, it's called the Covered Connecticut Plan. So I'll tell you a little bit about how it formed and how we got the dental piece introduced to it. And the kind of future plan for it, because we're not quite at the implementation yet of the dental piece. COHI, the Connecticut Oral Health Initiative, is part of a larger Medicaid coalition in the state of Connecticut. So we obviously represent the oral health and dental piece within the coalition. And one of the big things that we work on together almost every year is seeing if we can get the eligibility levels for Medicaid increased. So over time, we've been working a lot to increase the eligibility levels for caregivers and parents because we used to have a much higher level. We used to be at, I think, 175% of federal poverty level. And then with budget cuts, sometimes we lose progress and then sometimes we gain progress. So in 2020, we went from, I think, 155% of federal poverty level being eligible for Medicaid to 160% of federal poverty level, which meant I think that was about 4,000 parents that gained Medicaid coverage when that happened. So we were working off of that momentum and we were asking for 200% of federal poverty level to be covered under the Medicaid program, if you're a parent or caregiver, and then also seeing what we could do to expand for single adults, which is the Medicaid D population, to see what we could, if we could gain any ground there and get a higher eligibility threshold. What happened was that was not going to be on the table. That was not something that the legislature was ready to fight for, and that was not something that the governor was ready to approve. But there was a conversation about using some of the federal dollars that were coming in from COVID to see what we could do as far as really better subsidies for people that are lower income but fall into that coverage gap, to see if they could do something with the exchange. So that became, in 2021, became called the Covered Connecticut Program. We have a part-time legislature, so our legislative session is at the beginning of the calendar year. So we started forming this plan. And then one of the things that COHI brought to the table was, this might be a good solution. It's not Medicaid expansion that we were talking about, but it is something that could benefit a lot of people and get them good care. They would get a silver plan on the Connecticut exchange, which is called Access Health CT. I'm going to send you a fact sheet. So that's why I'm saying Access Health CT, just so you know when you see it on there, that's our exchange. And thank you, Colin, for putting in, I think you put the 1115 application in. Thank you. So one of the things that we raised was that there is no dental coverage for adults on the exchange. You can get an add-on, but they're expensive plans and they're not part of the traditional plan, right? You need to purchase the additional dental plan. And most of what is on there, unfortunately, is kind of expensive for the benefit that you get. And most of it has an annual cap. I think usually it's about $1,500. We were saying, if this is what you're going to say works for people that are making 175% of federal poverty level, that's not really reasonable. They're not really going to be able to use this plan. They're not going to be getting dental care. So we suggested that they look into using the Medicaid program as a base for that, and then also had a conversation about increasing the rates, which is something that we were able to accomplish this year, the first dental adult rate increase since 2008. So that's pretty exciting. In order to widen the pool, because we already have an access to care problem. So if you add more people to the pool, you also need to think about what you're doing to make sure that there are actually providers to be serving those people. So they did add dental and also non-emergency medical transportation through an 1115 waiver. And that will take effect this July, so coming up relatively soon. So what they did was actually start with just the silver plan, just the health benefit. That started July 2021 and was only for parents and caregivers, so the Medicaid A population. Now they're adding the Medicaid D population that makes up to 100, so single adults making up to 175% of federal poverty level. And everyone, the parents and caregivers that already got on the Covered Connecticut plan and the new enrollees in the Covered Connecticut plan will also be getting the dental Medicaid, assuming that everything goes well with this 1115 waiver, because I don't believe they've received final approval yet, but I could have things change fast, so I could have slightly outdated information. So that is the plan. There's also conversation about increasing this. There was a push in the legislature from the Senate Democrats who really kind of championed the Covered Connecticut program from the start. There was a push to do the increase now and add people up to 300% of federal poverty level. But there was not really the appetite to do that from other legislators, and certainly from our executive government and state agencies who were already concerned about the implementation and onboarding everyone. So the internal conversations, the bits that advocates hear is that they want to start with 175% of federal poverty level, and then depending on how that goes, maybe add people in phases up to 300% of federal poverty level. And then advocates are pushing them to consider maybe up to 400% of federal poverty level, and maybe there could be a small premium for the people between 300 and 400% of federal poverty level. So let me know if any of that was confusing or if anyone has questions, because I know I kind of ran through it quickly. And unfortunately, it's not implemented yet. It will be soon, but no one has the dental coverage yet. So I can't really say how it's going for folks in the community.
So just to kind of recap here, the waiver would utilize the marketplace to provide a health plan with the sort of standard silver level benefits that you would otherwise get in the marketplace, but then supplementing dental and non-emergency medical treatment via Medicaid. So they'd be getting the same benefits that would be available to a beneficiary. And this is for sort of the, you know, what I think we traditionally think of as like kind of like the coverage gap population between Medicaid and marketplace subsidies, in this case up to 175% of federal poverty level.
Yes. Yep. That's
cool.
Fantastic summary. Thank you.
Yeah. So I just, you know, when I saw this, I was just super intrigued because I think it's a really innovative concept, and, you know, one that is kind of like being added to, like, I think like a short list of ways in which states are pursuing some really creative approaches to, you know, solving some of these lingering holes in access to dental benefits, whether it be for Medicaid beneficiaries or people who fall in between those two programs, or veterans or people with disabilities. You know, I think there's just a lot of, you know, renewed innovation happening right now. All right, that ends my commentary on that. Any questions for Parisa on this?
Something I just want to say is that I think what was exciting about this for COHI and for a lot of the community groups that we advocate for is that dental is usually forgotten, oftentimes by decision makers. It's something that's kind of left on the wayside. So to see that we were able to make quite a bit of noise and have a lot of conversations with legislators, and they took it to heart and said, you know, they're like, well, what can we do on the exchange? Oh, and then really had the conversation of having legislators look at the exchange with us and see that there's not really anything. There might be something in name, but if you actually do a little bit of thinking through, like, what does it look like for you to pay for this benefit and use this benefit? It's really not gonna work unless you have expendable income. So to see, I think, a really creative solution to leverage the Medicaid program, and then also be able to leverage that conversation to say, and this is a good opportunity to make the Medicaid program better, because there's going to be more people on the Medicaid programs. And don't we want everyone to have dental insurance? Don't we want everyone to actually be able to use the benefit the same way that you're able to use the benefit on your state insurance? Speaking to a legislator or decision maker, because they have wonderful dental coverage. And in the state of Connecticut, and if you're a state employee, your premium actually goes up if you don't use your dental benefit, because they know that that's a good way to control, for example, diabetes, or manage for heart disease, or get your head and neck cancer screenings. So it's part of our health enhancement program here at the state. So we were able to leverage it for other conversations too, about access to dental care. And then also have an outcome, right? So we had good conversations from it, and then we also have an outcome where thousands of people in Connecticut that are in that coverage gap are going to get health and dental coverage.
Excellent.
Yeah.
Well, keep us updated on how that develops, or, you know, let us know if we can.
Yeah, absolutely. COHI is happy to be connected with the team.
Awesome.
Yeah.
All right. Why don't we open it up then to anybody who's got state updates, or anybody who wants to, you know, share any strategies that they're pursuing related to beneficiary and consumer engagement.
Can I ask a question first?
Of course.
About what was just explained. So with your 1115 waiver, you're offering a standalone dental benefit to certain individuals if they meet your federal poverty level requirements.
Yes.
I got lost somewhere. I'm sorry. And
oh, no, that's fine. That's fine. So the base of this is really using the exchange. So they're providing subsidies to people who are between current Medicaid eligibility levels, which for parents and caregivers, that's 160% of federal poverty level. For single adults, it's only 138% of federal poverty level. So it's much lower. So for everyone, no matter if you're a parent or not, up to 175% of federal poverty level, if you're between eligibility and that threshold, you're going to be eligible for a program called Covered Connecticut. And the main part of that, the base of that, basically means that you can go on Connecticut's exchange and enroll in a silver plan for free. And then along with that, because on the exchange for adult plans, they don't have, the big gaps is really oral health coverage, dental insurance. And then also, if you don't have good transportation, you don't get the non-emergency medical transportation the way that Medicaid programs have them. So those two carve-outs, essentially, dental insurance and non-emergency medical transportation, will be added on. So you'll have your card, your insurance card will be, mostly it will look like a silver plan exchange card, but it will also have, our plan is called Husky, which is actually kind of a terrible name. But it'll have the Medicaid, I think it's dehumanizing, that's my problem with it. But so it has the Medicaid dental and Medicaid non-emergency medical transportation symbols on it. So you have that coverage as well. I'm sorry to go into my fact about.
All right, thank you.
Yeah.
Can I just share real quick, Colin?
Of course, Nancy.
Yeah, you know, as we go towards implementation, our process is nothing like the one we heard about in Maine, where it's public. It's very much contained within DHS. So that's a concern because we don't really know what's happening until it gets rolled out. We hope it's in a draft form then, but it's very difficult to figure out what's happening. But I think the three main concerns that I have, and I share this with some people, maybe not with everybody, is timely implementation. So we're not still planning and not implementing a year from now. The second is the cap on the benefits, which for us appears to be, thanks to a fiscal analysis that was done, has been sort of fixated on a little over $600 per participant. And we don't think that's going to go very far on a yearly basis. And the third is the concern that I believe Maine shared and I've shared before, and that is we just haven't engaged the private dentists the way we need to. So those are kind of the three barriers to implementation, actually four, if you include the DHS planning process, that I'm wondering whether those are common barriers that we have, or are those just specific to our state? Thanks.
Any thoughts for Nancy on that?
I'll just say we work a lot with our department on lots of different things across many programs, and they are rarely as transparent as they have been around our adult dental benefit. And I really do think that the reason that they have been so collaborative is the combination of having statutory language that required them to, but they still could have not been as great as they have been, especially with the language that ended up in the budget. But also, I think the pressure they feel from all the public attention the benefit got in the media. So they really need to see this as a success, and they wanted to get these stakeholders on board talking about it as a success. And they had to be collaborative in order to make that happen.
Have your people talk to our people, please.
Nancy, this is Tanya in Kansas. I may have blanked out for a minute because I was making some notes about some of the other things I heard already this afternoon. Did you, will your coalition be at the table at all in the in the implementation process with DHS?
You're speaking to me, Tanya.
Yes.
No, not that I know of. I think it's all extremely internal. They're working on it already, and there's no table to speak of that we know of, that I know of.
Okay. I feel like our process in Kansas is going to end up being kind of a hybrid of things we've heard here. I've worked real hard to just try to tell the Medicaid director, look, you're so busy. I'm happy to convene people to work on this if you want. I'm not nearly as busy as you. You're so busy. It kind of didn't work, except she did, let me, help identify who'd be at the table. So it's going to be, we meet next week for the first time. It's going to be a ton of Medicaid staff. A bunch of people from the MCOs, and then the Dental Association, the Primary Care Association, and me. And because there won't be much other representation, I've been trying to talk to like as many stakeholder groups as I can to get a sense of what they want. So I've got like a survey out there. I'm speaking with some nursing home administrators on Friday, just all kinds of things. So I'm kind of going to force some community input in there, whether they like it or not. Anyway, that's all.
I think people are afraid of that if you force it, then you get a negative backlash, where they won't talk at all. And so I don't know. I think different people with more of a relationship may be able to get in there, but I think it's not an open process. It's not transparent that I can see. And it makes me nervous. And I'm sure it does other people as well.
That's too bad. I'm sorry. And I don't really mean force. It's Kansas nice. I'm going to be super nice and deferential as I tell them, here's what the entire state wants.
Midwestern sweet.
I like that. That's better than Kansas nice is really not nice. It's kind of, it just sounds nice. Like Midwestern sweet. Thank you.
Yeah, you got to watch us Midwesterners. We always seem friendly, but then when you turn your back, you're just in trouble.
Gonna bring the hammer down.
That's right. Sometimes we use hammers.
Hey, Colin, this is Paul Glassman. Can I jump in with a comment?
Sure, Paul.
Just a quick update on something happening in California, which is a little bit relevant to the last couple of discussions. I apologize. I joined this meeting late because I was on a call with the staff of what's called Covered California, which is California's version of the ACA exchange. And they have a work group. So opposite of what's happening with you, Nancy, in Hawaii, they have a work group, a very public process of looking at the benefit design and the requirements for the health plans to offer products on the exchange. They're now planning for a 2024 renewal, so there's a lot of time to move forward with it. So it's a very public, very open input, at least. Whether they adopt everything that's said, I don't know. But so they've asked me to present at their next work group meeting, and what they're particularly interested in is how, the overview is how plans could do better. Right now, they sell a lot of plans. They have 380,000 people with coverage under the exchange, so it's a pretty large number, but a pretty small percentage of them actually use the benefits. So how could they want to do better in terms of people who buy a plan actually using it? And so there's going to be opportunity to talk to them about the use of telehealth, outreach, community engaged services, a whole bunch of things that plans could implement that would allow them to do a better job. And then they're going to be installing performance metrics that we're going to try to help the plans think differently about dental care, not just sell a plan and hope they show up at a dentist's office, but to actually become more engaged in the process of seeing that people actually get care, that they are engaged earlier in the disease process, et cetera. So I'm just kind of excited about the fact that we have this forum and the opportunity to actually do a presentation to them, to the staff and the other members of the work group, which includes the plans themselves, to plant some ideas about doing things in a different way than dental care is usually done. So that's, I think, pretty opposite than what you just described in Nancy in Hawaii, where they're kind of, you don't hear anything until it's all over with. They're being pretty open about and soliciting input.
Thanks, Paul. Yeah, I mean, I think, this is an important conversation, and, it's kind of odd, like how rare it is that, when an agency asks this, this type of question, that their subsequent action is to actually ask the people who are using using the program about how it could work better for them. So, you know, I think we all have a bit of a responsibility to upend that dynamic to some degree. I did put in the chat some hopefully relevant research on this topic, but I'm also seeing that Jen and Brianna have kindly asked the group for, you know, if anyone's willing to kind of share the composition of their stakeholder lists that they're attempting to, you know, to engage in these discussions that might be useful for their purposes as well. So, you know, providers, patients, whomever else, like, you know, what kinds of groups are you you know, reaching out to?
Do you mind if I hop in with a comment?
Sure.
Okay. I was just thinking about the kind of issues, Nancy, that you're talking about with the transparency and some of the different kind of tactics and concerns. I think what Tanya's doing makes a lot of sense to me in a lot of ways. I consider myself sort of like pleasantly relentless and sort of like trying to be nice, but also like push my way into the room. But I know that's sometimes difficult for relationships too. So there's kind of this balance of, you know, do you have people that you can kind of trust and that will do a phone call with you to tell you things or give you a heads up, and then, or do you have relationships with someone, like a good relationship with a legislator who can be the pushy person for you, is sometimes a way to do it. And then also there's sometimes, as an advocate, when certain people are mad at you, that's not always a bad sign because it means that you're pushing buttons.
I'm very good then.
Yeah.
Because I push a lot of buttons.
Yeah, right. It's this mix, right? You don't want to get cut off, but sometimes a reaction is good, even if it's unpleasant. But I was thinking too about the stakeholders' comments and sort of how to be disruptive and make sure that people are hearing from different voices. So something that COHI has been doing really kind of amped up over the past 18 months or so is a lot of community conversations and focus groups and individual interviews with adults on Medicaid to understand their experience, and then really framing that as qualitative data. And we are going through, we've asked people who are willing to record the interviews with us, and we're going through encoding for main themes because it gives us the ability to kind of back up the messaging and say, you know, like we're just letting you know, like we've built partnerships with, you know, certainly we had established partnerships with our provider associations, you know, the dentists, the hygienists, the community health centers, but now we're also doing a lot of conversations with diaper banks and food pantries and, you know, people that are trying to use this benefit, having this experience. And there's nothing like having that, the insight from people that like, this is their life. Like they tried to get an extraction. They are in dental pain. They were told they have an abscess, but they can't find an oral surgeon. So we're able to kind of, in a way, it brings a little bit of distance because it's like, we're not making this up. I just had a conversation with, you know, we talked to 50 people, or we did this community conversation and this kept coming up. So to be able to deliver that almost like as a package or document and say, you know, like, this is what's coming, people are upset, and we're trying to just be the conduit for positive change, right? Like we're not attacking anyone, but we're coming to the table representing community. This is what matters to us. And I think that we've had more success in our advocacy efforts when we've been building those relationships with really like the people that we're at the end of the day advocating for. So I think a lot of it has been getting a level deeper and talking to also like faith leaders, like the Black faith leaders in Connecticut have been amazing partners for us because they'll go out and talk to their parishioners. They do like door knocking all the time anyway. So they've been adding like dental access questions to when they go and talk to people in the community. So that's been helpful because it's been good relationship building, but it's also been, a lot of times state agencies do fear people. I fear like people demanding things, people asking for change. So in a way we can be a messenger and say like, I'm not going to yell at you. I'm going to be super pleasant to work with, but I want to let you know that people are upset and here's what they're upset about. And maybe we can do something about it. So we're able to kind of position ourselves in this like friendly agitator way, which there's different pieces of that that may work or not work, I think, for different folks, but that's what we've been doing.
I feel like that's a skill I could use to develop.
The relentlessness or the friendly agitation?
The friendly agitation. I don't have any problem with relentlessness. Thanks, Parisa. That's helpful. All right, I'm eyeing the clock here. We are nearing the end of our time. Any last quick updates before we close?
I could add that we have Medicaid expansion in Missouri, in spite of the legislature trying to think of creative ways to kill it off. They did not achieve what they were after this session in that direction, and actually several other directions. So that's about another, I think, 250,000 adults who are currently in the process of enrolling for Medicaid eligibility. And that's going a little choppy, but it is happening. And all of those people will have access to the Missouri Medicaid adult dental benefit. So we're really, really pleased to see that rolling forward.
Colin, this is Mary with MDAC. Like Gary earlier, I never know something is really truly going to happen until it's signed. And so Hogan did sign the adult dental bill last Thursday. So we are good to go. We're moving forward. It's a January 1, 2023 start date. We also got a little bit of money in the budget for increase in Medicaid rates. So MDAC was asked to pull together a stakeholder group of providers to speak with Medicaid in terms about the application of the rate. So I pulled together rural, urban, suburban providers, safety net providers, private providers. We had our first meeting with Medicaid last Thursday. Very different perspectives to talk about options for increases, whether it's across the board or if it's across the board with a little bit more for special services, or if it's a hybrid model. So we're supposed to meet again next Tuesday to decide how to move forward. And that increase, Medicaid would like to see it go into effect on July 1st. It's nothing major. It's a little over, it's 20 million or a little over, but I think it sets the stage for future progress and movement on this, because the Joint Chairman's Committee issued a report and they would like Maryland Medicaid to look at dental reimbursements as compared to medical reimbursements. So again, step by step, they're getting it and things are moving forward. So, but it's signed, so onward. Thanks, Colin.
Awesome. No, thank you. Congratulations. It's been a long time coming. All right, folks, I think that's going to do it for us. We are at the hour. Thank you all.